Yes, and thank you for giving me this challenging presentation. But so let's try to see now that we know almost everything about the different conduits, how can we can match them to our patient in our practice. I have no declaration of interest. And well, the first comparison is a classic face-off between the radial and the Rita. And by the way, Toro, I don't see anything bad in a scar in the arm, to be honest with you. We all know that if we look at the biology and if we look at the function of the production of nitric oxide, the ITA is like the ideal arterial graft, and there is no doubt that in terms of histology and the production of nitric oxide, the ITA beat the radial. However, if that then translates in a better patency rate, I think this is a different story. Umberto, in a classical network meta-analysis looking at all the randomized trials that have compared the different arterial and venous conduits used in CABG, found no statistically significant difference in long-term patency rate between the two conduits, but I like to underline that the solidity of the evidence is very different from the two conduits. There have been so far 9 randomized trials totaling more than 2,000 patients for the comparison between the radial artery and the saphenous vein, and only 2 randomized trials and a few hundred of patients for the comparison between the Rita and the saphenous vein. Well, the RAPCO trial in group 1 was the perfect trial for the comparison between the two arterial conduits. 374 patients randomized to one of the other in group A. It's important, however, to note that in the RAPCO trial, the Rita was used as a free graft and not as an insitu graft. 10-year results were never fully published, but they were presented a couple of years ago at the AATS, and there was no significant difference in the patency rate of the two conduits. When it comes to clinical outcome, again, the RAPCO trial at 5 years found no difference in survival and event-free survival between the radial and the Rita. There is a lot of observational evidence. Bob contributed to the field with several studies. This is a propensity match comparison of more than 500 pairs, and there was no difference in survival between patients who received the radial or the Rita at the follow-up of more than 15 years. However, when the same group of investigators focused on a higher risk of diabetic patients, they found a statistically significant difference in favor of the radial artery. Humbert and I published a few years ago this meta-analysis of the propensity match study that compared the two arterial conduits. We found no difference in operative mortality and no difference in the incidence of deep sternal wound complication overall. There was a trend for lower operative mortality in the radial artery group, and when the beta was not skeletonized, the incidence of deep sternal wound complication in the beta series was significantly higher. We found a significantly longer survival for patients who received the Rita instead of the radial. However, when we look at the unmatched population, it's pretty evident that the patients who got the beta were generally younger and with a lower prevalence of cardiovascular risk factors, so suggesting that the treatment allocation bias can be the explanation for this finding. Tom Schwan recently published this seminal analysis of the STS database, more than 1 million patients, looking at the comparison of the two conduits. Again, he found no statistically significant difference in operative mortality with a trend toward lower operative mortality for the radial artery and a clear and statistically significant increase in the risk of deep sternal wound complication for the Rita. However, what I think is most important, and come back to what has been said before, it was able to show a clear volume to outcome relationship for the beta, which was not evident for the radial artery. It was suggesting that operator experience is important, in particular for the beta, and we have suggested the same in this meta-analysis that Faisal has already presented. So both deep sternal wound complication and long-term survival, the two most important outcomes of the beta operation, were significantly related to surgeon experience. We performed this network meta-analysis of all the clinical studies that have compared the radial artery, the Rita, and the saphenous vein, overall more than 140,000 patients. Briefly, for the comparison between the radial and the Rita, we found no difference in long-term mortality, no difference in perioperative mortality or in incidence of deep sternal wound infection. I guess there was a trend for lower operative mortality for the radial artery and the higher risk of the higher incidence of deep sternal wound complication in the beta series, but that did not reach statistical significance. It's important to remind everyone that in the recently published guideline, the radial artery got a class 1 indication, whereas the Rita got a class 2 indication because of the difference in the solidity and even in the result of the published studies. So to conclude this talk, I think that we should say that both arterial conduits have excellent long-term patency rate, both superior to the saphenous vein, but currently there is no clear-cut proof of superiority of one over the other. The two arteries have different indication and contraindication and must be considered a complementary alternative. Surgeon experience in skin selecting which arterial graft to use. This is my personal scheme for the choice of the second arterial conduit. I prefer the I prefer the radial artery in patients with high risk of sternal complication, obese, diabetics, especially in combination, and when I have to graft distal or multiple targets. I prefer the Rita in case of moderate target vessel stenosis and clearly in lack of ulnar compensation. In general, I think there are two main considerations that need to be made when selecting which second arterial graft to use: the complexity of your grafting strategy and the surgeon experience. For more complex grafting strategy, again, multiple target, Y, baby Y, whatever, the radial artery is a great option. Just make the operation easier. And then, for the same reason, it's the best option for surgeon at the beginning of the learning curve with multiple arterial conduits. For more straightforward operation and grafting strategy, and for surgeon with large experience, well, the Rita is a perfect option. So, well, a few years ago, we published this paper where basically we proposed a flow chart for the choice of the conduit. I don't think the flow chart is important, but the key message here is that you really need to individualize your conduits to your patient, and this is probably the most important key for good outcome in this type of surgery. Thank you.